Hola, hola. Buenos días. Quiero darles la bienvenida a la sesión de casos interactivos. Hoy día trataremos patología de urgencia. Les voy a pedir que por favor se sienten del pilar hacia adelante, del pilar de atrás hacia adelante, porque más atrás no hay teclera. Entonces, si quieren votar, necesitan apretar las tecleras. Vamos a tener a 3 invitados este día para que nos ayuden con los casos que van a mostrar. El primer invitado, ya lo han visto varios días, es un conocido radiólogo de abdomen, el doctor Sahani, que trabaja en el Massachusetts General Hospital. Y lo voy a invitar por favor a que pase para que nos muestre su presentación y veamos cuánto sabemos. Cuando termine cada caso van a salir las alternativas, él las va a leer y cuando diga voten, ustedes apretan la teclera y van a salir las estadísticas y van a ir votando. Gracias.
Great. I appreciate the kind introduction. This is my last presentation. Had an amazing time in Santiago so far, and I wish you good luck for the rest of the meeting. So the way this will go is you have your clickers. The options are from 1 to 5. I have A, B, C, D as options. So A will be 1 and E will be 5. So that's how you will choose it. So, and I want to acknowledge my friend Kumar Chandrasekharan from University of Indiana for sharing some of his work with me for this. Now, the focus of this case presentation is on pancreas, and I want to share with you some cardinal rules of surgery. Now, my wife of last 21 years is an anesthesiologist, but before she started her residency, she did a surgical internship for 1 year. And in her first week, the chief resident told her there are 3 cardinal rules you need to follow. One is eat when you can, there is no lunch break, or sleep when you can, and don't mess with the pancreas. So these are the rules, and that's the focus of this presentation is don't mess with the pancreas, okay? So you're with me? Let's do it. Okay, case number 1. 82-year-old male with weight loss. You have 2 images shown. The top is a PET CT and a CT image, and I'm going to show you options. These are the options. I won't read it out for you. You have to pick one of the 5 options. Again, A means 1 and E will be 5. So you have few seconds, so you're polling, you start polling now. So 41% said pancreatic lymphoma, 30% pancreatic ductal adenocarcinoma, and then other options. So let's look at what is the right answer. So right answer is the 41% who picked is C, is the right answer. This is pancreatic lymphoma, and I will tell you why this is pancreatic lymphoma. The primary pancreatic lymphomas occur in 2% of cases. Most of the lymphomas secondarily involve the pancreas, and the way you differentiate that is there is no distal lymphadenopathy. You have a mass in the pancreas, no mediastinal adenopathy, bone marrow is negative. And 75% of cases are actually not diagnosed preoperatively because of its imaging appearance. And misdiagnosis is because it doesn't look like a typical tumor. Now, the interesting feature is generally there is a focal or diffuse involvement of the pancreas. There is a mass. It doesn't cause pancreatic duct obstruction, which is typical or a hallmark of pancreatic ductal adenocarcinoma. Lymphadenopathy, when present, goes up below the renal vein, which is again unusual for pancreatic ductal adenocarcinoma. There is vascular encasement, but there is no narrowing of the vessels, which is more common with ductal adenocarcinoma. And again, calcification is not a feature. So here you can see after treatment, before and after treatment, the pancreas almost turned normal. And this is one large infiltrative lymphoma involving the pancreas, but also going into the spleen. So that's how they appear. and this is our case. And PET is amazing modality. PET, almost all the time, lymphomas are super hot on PET, which is not always the case with ductal adenocarcinoma. So that was great. So we are getting warmed up now. So let's do case number 2. 55-year-old male with weight loss, epigastric pain, and history of diabetes. You have 2 images. The image on the top is a contrast-enhanced MR image, and the bottom is a T2-weighted fat-saturated image. These are your options. What is the next best step? So 27% said repeat MRI in 4 to 6 weeks, and 32% said ERCP followed by steroid therapy, and I think 25% said PET-CT scan. Actually, all the answers which you have picked so far, in some ways are correct, but the most appropriate, given these features, you don't want to miss something bad, will be ERCP followed by corticosteroid therapy. This feature is very typical for autoimmune pancreatitis, where you have swelling of the pancreas. There is no ductal dilatation, no vascular encasement, and the swelling could be focal or diffuse. So the diffuse enlargement is seen in more than 70% of patients. And here you can see the entire pancreas is swollen. It appears like a sausage. The acinar pattern of the pancreas is lost, and there might be some, but not a lot of inflammatory changes in the vicinity. 30% have focal mass lesions. They tend to be hypodense on CT and MR, and if we have PET-CT, they can be hot, and on delayed contrast enhanced images, they show enhancement. Capsular rim, which is considered pathognomonic, is present in about 30% of patients. We call this as a halo. So you see this, pancreas is featureless, and then you have this low density rim around a high density pancreas. This is a pathognomonic feature for autoimmune pancreatitis. And often when pancreas is affected, bile duct is also affected. The pancreatic duct is attenuated, not dilated, and bile ducts might also show stricture. And now when you look at the cross-sectional imaging, the difference between ductal adenocarcinoma and autoimmune pancreatitis is you notice that there is a thickening of the bile duct, and there is gradual tapering and the enhancement. You can see enhancement, and even the gallbladder might show increased enhancement. So these features which are favorable for autoimmune pancreatitis, and we also know it is a part of a multi-system disorder. Now we call this as a IgG4 related disease, and kidneys are affected, lymph nodes are affected, lungs might also be affected, and salivary glands are other areas that might be affected. So you need to look for those things. Okay, that was great. So now we move on to case number 3. The history, 65-year-old male with weight loss. You have 2 images shown here. These are CT scan images in the top, bottom and top of the liver, middle of the liver, and these are your options. What is the most common likely cause of his symptoms? So 55% said neuroendocrine tumor, 25% said pancreatic cancer, 13% said renal cell carcinoma, and then small percentage said lymphoma or serous cystadenoma. So sometime majority doesn't rule, sometime minority might be in the right, for the right answer. Now, first thing you notice is kidney is missing on the left side. And second thing you notice is there is multiple lesions in the pancreas, at least 2 of them you see that. That would favor, if you see multiple arterially enhancing lesion in the setting of absent kidney, the first diagnosis should be renal cell carcinoma. And serous cannot be a diagnosis for multifocality and weight loss. Serous cystadenomas tend to be asymptomatic. And again, neuroendocrine tumors usually are not multifocal except in the setting of some MEN syndromes. So diagnosis, differential diagnosis is metastasis, neuroendocrine tumor, pancreatic splenoles, solid serous tumor of the pancreas, and this is for any hypervascular lesion. And we need to also consider other metastases or non-Hodgkin's lymphoma for hypo or iso attenuating lesions. So case number 4. 19-year-old Caucasian female with recent onset abdominal discomfort, no prior history of note. And we have 2 CT images, one in the middle of the liver and one a little bit lower down. So these are your options. The most likely diagnosis is A, B, C, D, or E. So 51% said 4, which is solid and pseudopapillary tumor. 25% said mucinous cystic neoplasm, and then others give other diagnoses, including pseudocyst. Now, let me tell you first thing why this is not a pseudocyst. The reason it is not pseudocyst is because there is solid component with the lesion. There is a lot of solid component. If you see a cystic lesion with a solid component, that is a cystic neoplasm or a solid neoplasm that has degenerated. It can never be pseudocyst. Serous cystadenomas is not possible here, given it is predominantly solid in the periphery and purely cystic. So the diagnosis is solid and pseudopapillary tumor. And one reason is the age of the patient. These tumors occur in younger age group. I want to show you the images of this patient in ultrasonography. That is MRI. And you notice that lesion is pretty bright. And this is another patient where you can see on CT scan a solid hypodense lesion with a thick wall. That is a very typical appearance, but the age is the most important factor. And these lesions tend to be well defined with a capsule. They don't cause pancreatic duct dilatation. They rarely cause pancreatic biliary obstruction or vascular encasement. And these are in older patient, if someone is like in 40 or 50 years with the same morphology, your first diagnosis will be a neuroendocrine tumor with cystic degeneration. So, and since these occur in a younger age group and they have malignant potential, we take them out surgically almost all the time. You don't follow these. They are not benign lesion. So that's great. Case number 5. 78-year-old woman with early satiety and abdominal pain. You have an MRI image, a T2-weighted image, which is shown here, and these are your options. What is the most likely diagnosis? So 52%, again, I hope they are the same 52% who answered the last question. It said 5, which is indeed the correct answer, and I will tell you why this is the right answer. First of all, there is no pancreatic duct dilatation. This lesion has numerous cysts, that is a microcystic morphology, so mucinous cystic neoplasm is out of question. Pancreatic cancer is out of question, given it's a T2 bright. There is no duct obstruction. An intraductal papillary and mucinous neoplasm is out of question because the duct is not dilated again. So it's serous cyst adenoma. And as we know, serous cyst adenomas are benign tumors. They tend to occur in older women. Therefore, we call them as a grandmother tumor. The typical morphology is this microcystic pattern. There are numerous, like thousands of cysts, which are very small, and the septations inside. That is the typical appearance. In a majority, they are like 80% to 90% are seen in female older women, and they can be seen anywhere, but head and proximal body is the commonest location. The typical appearance is central scar, but central scar is seen only in 30 to 40% of patients. But the morphology, a lobulated outline, microcystic pattern, no encasement of vascular structure, no pancreatic duct or bile duct dilatation, those are the features for serous cyst adenoma. This you can see. Another case with a central scar and a microcystic morphology, lobulated outline. That's the classic look for serous cyst adenoma. Some of these patients can show calcification centrally in the region of central scar, but that is not needed to make the diagnosis. The morphology is good enough. Serous cyst adenomas, about 20% have a variant morphology. You can have a macrocystic type in about 15%. Like here, you have a bigger size cyst. The way to differentiate them from mucinocystic neoplasm is the septations. They are much thicker, and also there are microcystic component associated with macrocystic component, which is unlike MCN. Here, this is more macrocystic, but look at the lobulated outline, which is not seen in MCN. Some of these lesions could be solid, especially the ones which are sponge variety of serous cyst adenomas. Their spaces are really tight, and they can light up in the arterial phase. Again, on CT, the diagnosis is tough, but on MR, these are extremely T2 bright, and you can appreciate the microcystic morphology on the delayed phase. And the one thing to remember is, despite the size of these lesions, there is no obstruction of various structure. This is again another case. Here, the large tumor causing mass effect, but not necessarily obstruction of structure. Now, in von Hippel-Lindau syndrome, there can be diffuse serous cyst adenomas in the pancreas. Like here, you will see multiple, and their morphology could be variant, but you don't do anything about it. You in von Hippel-Lindau disease, you are worried about neuroendocrine tumor. You don't do anything about serous cyst adenomas. So we move on to case number 6. 45-year-old woman with abdominal pain. A CT, contrast enhanced CT image through the mid-abdomen in the region of pancreas is shown. These are your choices. The most likely etiology is amazing. 71% picked mucinous cystic neoplasm, and that is indeed the right answer. Small percentage picked other diagnoses, and I can understand the conundrum why you all picked some other diagnoses as well. But let's look at this case. First thing you notice is the age, 45-year-old women. In the tail of the pancreas, we see a large, well-defined lesion with septations and macrocyst. That morphology, that age, is typical for mucinous cystic neoplasm. This cannot be a pseudocyst because pseudocysts don't have septations. Patient have no prior history of pancreatitis, so you have to think of cystic neoplasm. And it cannot be serous cyst adenomas because serous cyst adenomas, as we learned in the previous case, tend to be microcystic. They have a lobulated outline. And of course, these cannot be ductal adenocarcinoma of the pancreas. Now, the next question for you. Given that we have made the diagnosis, what is the best next step? You have to pick one of the 5 options. Surgical consults, almost 70%, amazing. That is indeed the right answer, because once you see a mucinous cystic neoplasm, there is no further imaging needed. This patient needs surgery because mucinous cystic neoplasm, as we know, these occur in relatively younger age groups, somewhere in like in 40s or 50 years. About 30% are malignant at the time, but almost all of these lesions will turn malignant at some time. Since these occur at a younger age group, if you leave these alone, they will turn into cancer and they will cause metastasis. So once you diagnose, you almost always take mucinous cystic neoplasm out, and remember the morphology. The typical morphology is the macrocystic appearance. Occasionally they can be unilocular, and the way to remember is they have very thick wall. They occur in a younger age group, thick wall, 85% occur in the body and tail. They can show calcification, and actually calcification correlates with risk of malignancy in those lesions. And since these are almost always malignant or pre-malignant, they are taken out. Just want to show some of the morphology. And again, I as mentioned, you take these patients out for surgery irrespective if they are malignant or not, but when there is presence of mural nodule, or if this lesion is greater than 5 centimeter size, or if the pancreatic duct is dilated or CBD is obstructed, that is invasive cancer at that time. And if this lesion is detected in older patient, which is uncommon, let's say an 80-year-old we see under 2 centimeter lesion, of course the risk will be much lower there. And if there is no solid component, those patients we tend to do follow-up. And the patients who have like somewhere in their 60s and we see a smaller lesion, no solid component, in those cases we will do endoscopic ultrasonography to see if they have malignant component. Otherwise, almost always we take these patients out. So case number 7, we are doing great. 58-year-old man presented with abdominal pain and weight loss. You have 2 CT images in the region of head of the pancreas. Your questions are as follows. The most likely etiology. Amazing, 90%, that's awesome. That's wonderful, given that there are only 2 images I provided. And so next question for you. Based on the images, the tumor is likely to invade what? You have your 5 options, pick one of those. Superior mesenteric artery, 56%, splenic vein, 40%, and 2% said transverse mesocolon. So let's look at the answers now. Okay, so the diagnosis, as you all got it right, pancreatic ductal adenocarcinoma, as you can see, low density mass, encasing vascular structures, causing pancreatic duct dilatation. Those who did not appreciate, that is the pancreatic duct stops here, and that's the low density mass, so that's the right diagnosis. But it is the transverse mesocolon that is being invaded. Like as you can see here, the tumor is extending. Superior mesenteric artery is not involved, splenic vein is not involved, and we notice that this area is the region of the transverse mesocolon, which is affected indeed by this. And I can understand the conundrum when you have only few images to make that diagnosis. So the thing to remember is, in pancreas, if you see abrupt termination of the pancreatic duct, that is a bad sign. That could be an early sign of cancer. Once you have recognized the lesion, you need to stage it And there are two terminologies, as we learned from yesterday's Alvaro's talk, is you need to differentiate abutment from encasement. Whenever tumor is wrapping less than 50% of the lumen of the vessel, that is abutment. When it crosses more than 50% of the lumen, that is encasement, so you need to look at that. If there is narrowing of the vessel, that is encasement. We call it a teardrop sign for superior mesenteric vein. And we also know that 10% of these tumors can be difficult to see, especially on CT and MR, and these tend to be like less than 2 centimeter size lesion, and we need to do alternate imaging techniques. Now, one way to differentiate this from chronic mass-forming pancreatitis is if you can see duct going through the mass on MRI, what we call it is a duct penetrating sign, that is more suggestive of chronic pancreatitis. But I want to emphasize differentiating chronic pancreatitis from pancreatic adenocarcinoma is not an imaging diagnosis. We always have to get endoscopic ultrasonography biopsy, and in certain cases, serological markers to rule out autoimmune pancreatitis. So you did great with the last case. Case number 8. Okay. 57-year-old female with abdominal pain. Now you have 2 images. Ignore this. This is not a problem. This is where the problem is. These are contrast-enhanced MRI images. You look at these images, and now I'll show you your option. The most likely diagnosis is. So 65% said neuroendocrine tumor, and that indeed is the correct answer. Just few things. I think I don't have to say much about ductal adenocarcinoma. We know that. They are not hypervascular. Acinar cell carcinoma are functioning exocrine tumors, but they occur in older men. And this is not the morphology for them. They tend to occur in older men and not in women. And their symptoms are typically painful skin lesion because those tumors excrete a lot of lipase that causes fat necrosis. And likewise, serous adenoma is not the right diagnosis. Patient is symptomatic and not the right age. And metastasis, unless there is known primary, and if there is multifocality, we have to always suspect a primary tumor. And we know that, as we learned from yesterday's talk, that neuroendocrine tumors of the pancreas, they occur from stem cells in the ductal epithelium. And 75% of these are sporadic. That means we don't know who is at risk, but in about 25% occur in patients who have certain genetic variation like MEN syndrome or von Hippel-Lindau disease. The typical appearance that we see is these tend to be T2 bright, T1 dark on MRI, and almost all of them arterially enhanced. I would say about 80 to 90% will arterially enhance. 10% of neuroendocrine tumors are isodense to pancreas on all the sequences. And it is so critical when you are looking at neuroendocrine tumor that you look at multiple sequences. And I have personally gained from my collective experience that in certain cases diffusion-weighted images help you, but T1 FATSAT pre-contrast images are extremely helpful in detecting these lesions, and these lesions tend to be softer and they don't cause ductal obstruction. And as you can see, arterially enhancing. On the delayed phase, they still retain some contrast. I think one differential that is very important, especially in the tail of the pancreas, is the intrapancreatic splenule. As we know, splenule can be present in anywhere from 2% to 10% of patients based on the literature, and splenule follows the signal intensity of spleen. Now, this can be a challenge in a patient who had splenectomy, but if you look at T1, it follows the spleen, arterial phase, it follows the spleen, and even on delayed phase, it follows the spleen, and these tend to be more homogeneous and are not diffusion restricted. So that is how we differentiate. So case number 9, 36-year-old with acute abdominal pain and nausea. You have an abdominal CT, contrast-enhanced abdominal CT image right in front of you. and these are your options. The best next step is okay. 37% percutaneous drainage, 25% is surgical consult, and 30% ERCP. So let's look at the answer, and I will give you explanation for that. I would say all your answer could be correct in some ways because you are focusing on necrotizing pancreatitis. You are looking at necrosis, and as we know, necrosis is a high risk for infection, and these patients develop septicemia. So these patients need to get antibiotics, admissions, and also debridement or percutaneous drainage depending on your facility. But what is important is you look here. There is a vascular pseudoaneurysm, and those are at high risk for rupture, and therefore recognizing those complications is critical. Getting a catheter angiogram and then doing appropriate management with embolization is critical. You know, the way we report acute pancreatitis, we need to look for necrosis, and this is very subjective. We call whether no necrosis, under 30%, 30 to 50%, and more than 50%, and based on the percentage, the risk and prognosis changes for the patient. We need to look for wall thickening and leaks. Because that can result in more complication and morbidity for the patient. For a year, you see necrotizing pancreatitis, small bowel obstruction, a lot of edema of the bowel wall. Those are the important things. You look at the duodenum, there is thickening of the duodenal wall. And these patients are at high risk for developing leak or fistula, especially if they intervene, because bowel is very friable. We need to report the size and location of the collection if there is infection present. Now, one thing you need to remember is infection can be difficult to diagnose on imaging unless there is presence of air. Now, air is present only in minority of patients. Rim enhancement around a loculated collection doesn't mean infection. So how do you recognize infection? If your patient is sick and there is a rim enhancing loculated collection, you raise a concern for infection, and they have to aspirate to figure out infection. Otherwise, in absence of air, you can never say if it is infected or not. Vascular complication can be dreadful. You need to recognize those upfront, especially, you know, pseudoaneurysm more important than thrombosis, and they have to be managed conservatively. Intervention. And splenic artery pseudoaneurysm are more common, followed by gastroduodenal artery, and then common hepatic artery pseudoaneurysm. So great, you did great. Case number 10. 49-year-old male has a CT 8 weeks after the onset of acute pancreatitis. So you have these CT images. History is patient at 8 weeks prior had history of acute pancreatitis. Now this is the question. The best terminology for the finding is so we have 60% saying walled-off necrosis, 20% saying pseudocyst, and then, you know, some minority saying other diagnosis. So let's look at what is the diagnosis. And indeed, majority are correct. It is a walled-off necrosis, and that is critical to define, because what happens is if you say pseudocyst, they will send the patient for intervention. And walled-off necrosis, you can't drain it with regular catheter. These generally require surgical debridement. So your terminology, how you use it, has a prognostic implication as well as management implication. So just to again review the revised Atlanta classification, I know we heard in the previous talk from our gastroenterology colleague, you have pancreatitis is divided into interstitial or necrotizing pancreatitis. Interstitial pancreatitis has lower risk, but it has certain manifestations on images. It doesn't have any subcategories initially, but for necrotizing pancreatitis, we have pancreatic and peripancreatic necrosis. We have only peripancreatic necrosis, or rarely only pancreatic necrosis. Generally, there is pancreatic and peripancreatic necrosis present. Between 1 to 4 weeks, there are acute collections. We don't call them phlegmon, and generally they don't have like thick wall of enhancement. Whereas in this, in 4 weeks, you have acute necrotic collection, and after 4 weeks, this turns into pseudocyst, and this is called walled-off necrosis. And as you rightly mentioned, because these have management implications as well as prognosis for the patient. Great job. Case number 11, 45-year-old male with history of alcohol consumption, presents with recurrent abdominal pain and weight loss. You have 2 CT images. Just in the interest of time, I would say you have to focus here around the head of the pancreas. And I know these images will disappear once I put my options. The most likely etiology is okay, 60% pick groove pancreatitis and 30% pick chronic pancreatitis. Let me say why this is not chronic pancreatitis. Chronic pancreatitis need to have atrophy, calcification, all those things in the pancreatic parenchyma. And if you look at the head looks pretty healthy. Why this is not acute pancreatitis, which I didn't put an option like a typical pancreatitis, the pancreas itself is not swollen, and what you notice is this edema and swelling is in the pancreatic groove. There is also thickening of the duodenum, so that location and appearance suggest groove pancreatitis. Now, it's important to differentiate groove pancreatitis from a typical acute pancreatitis because management is different and etiology is different. The commonest cause for acute pancreatitis is gallstone disease. Second common cause is alcohol consumption. But groove pancreatitis is not related to that. It is related to ectopic pancreatic tissue. So management generally for these type of cases is endoscopy and intervention. So this is groove pancreatitis. They occurs in males between 40 to 60 years of age. The history of alcohol abuse might be present. Etiology is unclear, but the location is typical. You see that edema, inflammation right in the groove. Rest of the pancreas looks okay. Also, there are cystic changes sometimes in the duodenal wall. These are actually pseudocysts within the duodenal wall, and it is called cystic dysplasia of duodenum because of those pseudocysts. And again, this is more flared example with those cystic changes. This is a different case of groove pancreatitis. Notice there are chronic changes in the pancreas because at times what happens is it obstructs the pancreatic duct over time. And you need to be cognizant of the differential diagnosis and mimics that can look like groove pancreatitis. So this is not an imaging diagnosis. You always recommend endoscopy to rule out the etiology for groove pancreatitis. And we move to the final case. This is 56-year-old female with diagnosis of pancreatic mass on outside CT. Look at these images. Do your best. And I'm going to, the most likely diagnosis is. This is a tough case. Oh, wow, 85%, annular pancreas, amazing. That's indeed is the right diagnosis here. So annular pancreas is the right diagnosis, and the way you recognize is you see the pancreatic tissue going around the duodenum, completely circling around the duodenum, and if you also notice there is proximal gastric outlet obstruction, or at least some emptying delay with food content and contrast in the duodenum, in the stomach and proximal duodenum. And as we know, this is a congenital anomaly. A pancreas develops from dorsal and ventral anlaga, and it rotates and fuses. So at the time during in utero, if the rotation is not complete, if part of the dorsal anlaga stays around the duodenum, it creates a annular pancreas, and it generally presents in pediatric age group, but some of those not too severe cases can present in adulthood. So this is sometime an incidental finding, but in adults it might cause outlet obstruction or peptic ulcer disease, and we need to recognize those. Sometime the diagnosis is difficult on CT, and endoscopy might be needed. So with that, I really want to thank you all for your amazing participation. I thank you for inviting me to be part of this amazing Congress this year. I wish you all good luck, and thank you again for listening to me. Muchas gracias.
Quiero agradecer su participación en el Congreso y en permitirnos aprender más sobre el páncreas.